My name is Harsha Shanthanna. On behalf of our team, I'm presenting our study abstract titled The Benefit of Adding Steroids to Local Anesthetics for Chronic Non-Cancer Pain Injections, a systematic review and meta-analysis of randomized controlled trials. Chronic non-cancer pain can be considered as pain that persists beyond the period of normal healing. More than 100 million adults were affected by chronic non-cancer pain in the US alone in 2008. Most of these conditions are musculoskeletal in nature, and we observe that medical therapies are often ineffective or unsatisfactory in controlling their pain. Injections are commonly employed by physicians and contain corticosteroids used along with local anesthetics for these conditions. However, there seems to be limited preclinical evidence and inconsistent clinical evidence regarding the benefit of adding steroids. Moreover, steroids can have harmful effects, especially as these patients get multiple injections over many years. Our study was a systematic review and meta-analysis of randomized controlled trials published in English. Trials would compare local anesthetic versus local anesthetic plus steroids for chronic non-cancer pain injections. We did a comprehensive literature search involving Medline, Embase, and Cochrane registries, along with reviewing bibliographies of relevant reviews published over the last 5 years. Study selection was done by paid reviewers using an online tool called Distiller. Reviewers would work independently and in duplicate. Data abstraction was also done in Distiller by paid reviewers, and we extracted study characteristics, outcome measures, as well as risk of bias measures. Studies were pooled for outcomes using a random effects model whenever there were more than 2 studies per outcome domain. We also pre-specified our subgroup and sensitivity testing hypothesis. Binary outcomes were reported using relative risks with 95% confidence intervals, along with number needed to treat whenever results were significant. Our outcomes included chances of successful pain relief, functional improvement, and adverse effects. We also assessed the effect of number of injections and steroid dose on pain relief. In total, we had 4,249 abstracts, out of which 612 full-text articles were screened to obtain 70 studies. In this abstract, we only report studies that measure pain as either binary or categorical outcomes, and that allowed us to pool outcomes as a measure of success or failure. So for this, we have included 42 studies. Out of 42 studies, pain relief outcomes were reported between 2 to 6 weeks by 20 trials involving 1,601 patients. The relative risk was 1.53, favoring the addition of steroids to local anesthetic, and was significant statistically. The I-square, a measure of heterogeneity or inconsistency, was 84%, and the number needed to treat was 6.7. Pain relief between 2 to 4 months were reported by 23 trials involving 1,996 patients, with a relative risk of 1.04, although favoring local anesthetic and steroid. It was not statistically significant. More importantly, the interaction test for the subgroups was significant, indicating there was potentially a different subgroup effect between studies that reported outcomes 2 to 6 weeks and studies that reported between 2 to 4 months. When success over time in single injection studies were assessed, meta-regression showed that there was no statistically significant difference, which means when studies using single injections followed their patients over a long period of time, there was no difference in outcome measures. Similarly, effect of steroid on success or failure was looked at, and it was not found to be significant with a p-value of 0.09. Hence, the dose of steroids did not seem to influence the success rate. In conclusion, our study shows that better preclinical studies are needed to understand the role of steroid injections in chronic non-cancer pain, and there could be a potential placebo effect. physicians should consider limiting the number of injections and steroid doses.